تمام. مرحبا للجميع. فعندنا تحدي للمتحدثين يحاولوا يخلصوا قبل بربع ساعة لحتى نقرب القهوة شوي. تمام. طيب، هاي الجلسة راح تركز على الفئات الأكثر ضعفاً. يمكن إحنا لما نحكي عن الحماية الاجتماعية هي الفئات اللي إحنا بتكون أكثر شيء أولوية، لكن مرات في صعوبات موجودة في الوصول لإلهم، وفي مفاجآت ممكن تكون بالنسبة للوضع اللي بواجهوه. فأنا يعني ما راح أطيل، راح ننتقل للمتحدثين، بداية مع الدكتورة مايا سيردينج، واللي راح تعطي تقديم على الورقة على تحقيق شمول الأشخاص ذوي الإعاقة بالتأمين الصحي في الأردن، تحديدا في التركيز على الشباب. فإن شاء الله أنه هي موجودة معنا أونلاين.
Yes, good afternoon, everyone. Let me just share my screen.
Right. And you will have, I think, 10 minutes for the presentations. So we'll try and keep to the time, please.
Yes, I will do my best. Okay. Can you see the presentation?
Yes.
Great. Okay. Good afternoon, everybody. Thank you to the Economic Research Forum for the invitation to present. My name is Maya Sieverding. I'm an assistant professor at the American University of Beirut. And the presentation today is on health insurance coverage for persons with disabilities in Jordan, a focus on youth. So health insurance, let me put myself in presentation. Health insurance lies at the intersection of several major international agreements to which many of the Arab states, including Jordan, are party. One of these is the Sustainable Development Goals, which commits countries under Target 3.8 to achieving universal health coverage for the full population. And universal health coverage means in brief that all individuals can access the appropriate healthcare that they need without suffering financial hardship. In the Convention on the Rights of Persons with Disabilities, states also recognize the rights of persons with disabilities, which I'll abbreviate in this presentation to PWD, to equal access to healthcare. And Jordan is among the countries that has committed to both of these international agreements and which has made some recent policy steps towards their achievement, which I'll discuss at the end of the presentation. I would like to note that I'm focusing today only on health insurance from a financial aspect. And it's well recognized that another very important aspect of healthcare access, particularly for persons with disabilities, is be able to reach appropriate services that are of the type that they need without discrimination, without stigma. And this is unfortunately an area under which we don't have enough data to assess the progress in the kingdom. In general, from the financial perspective, though, health insurance is particularly important for persons with disabilities for two reasons. First of all, persons with disabilities tend to suffer from higher rates of poverty than the general population. This is globally, both due to lack of access to employment and education, due to accessibility and other barriers, and due to disability-specific health costs. Many disabilities come with associated costs or can be addressed through specific assistive technologies or that require specific services, which can help mitigate the extent to which the disability inhibits a person's participation in society, but which have costs. Health insurance can therefore be part of an empowerment-based approach to social protection for persons with disabilities that enables to enable their full participation in society. And so this is really a shift that we're seeing in the social protection field, away from a sort of charity-based model for persons with disabilities and towards policy mechanisms that aim to enable their participation in society through the provision of appropriate accommodations. And for anybody who's interested in this topic, there was a report produced by ESCWA a couple of years ago that focuses on empowerment-based social protections for countries in the Arab region, not only Jordan, which I really highly recommend. It's a very comprehensive discussion of the topic. However, in part due to limited data, there have been very few assessments of the degree to which countries in the Arab region have actually achieved health insurance coverage for the disabled population. To some extent, this is still true for Jordan as well. However, there are some relatively recent sources of data in the country that are allowing us to do a very preliminary assessment of the degree to which the population with disabilities is covered, in fact, by health insurance. So one of the key sources of data that is enabling us to take a closer look at health, disability and health insurance in Jordan is the 2015 census, which implemented the Washington Group for Disability Statistics new recommended measure for assessing disability. And this measure has been well demonstrated to produce a much more nuanced view of disability, not only in terms of the type of disability, but also its severity, that allows for typically more accurate estimations of disability. And so what the census data show us is that 11.2% of Jordanians and 10.8% of non-Jordanians have some form of disability across the 6 domains that you can see in the graph. Visual disabilities are the most common, followed by disability in the area of mobility. These vary in severity. There's usually 1 to 2% of individuals in the category are unable to perform the function at all across the domains. And in the rest, there are individuals who face different levels of limitation, either a moderate or medium level of disability. So this really suggests that the disabled population in Jordan has diverse healthcare needs, and it's a fairly substantial percentage of the population. As we expect, and also see in global patterns, the prevalence of disability rises considerably with age. In Jordan, this is particularly true starting around age 50, where we see that above age 60 to 64, nearly a third of the population has some form of disability of whatever severity and in whichever domain. At older ages, women have slightly higher levels of disability. At younger ages, it's more common among men. And the key implication from a policy perspective of these patterns is that there will really be very significant implications, both for health needs and for care needs, for social care needs, among the growing older population of Jordan. Jordan does have a relatively high fertility rate. It is currently a fairly young country, but the number of elderly individuals is expected to grow quite rapidly over the next few decades. And at these levels of disability, there will be really significant healthcare needs among this population. So while the discussions on disability often do focus on this older population, which has higher prevalence of disability, we have another new data set, which is the Survey of Young People in Jordan, which was sponsored by UNICEF, that is showing, collected the same measure of disability among youth. And what we find is actually much higher rates of reported disability among youth, and particularly among Syrian youth, although also among Jordanian youth than we saw in the census. So rates of 20% among young people aged 16 to 30, which is really very high, and up to around 30% among some Syrian youth. Most of this is low to moderate disability, so individuals who reported that they have a little bit or a moderate amount of difficulty performing functions in the different domains. But one of the very interesting differences we found when delving into this is that a lot of the difference comes from individuals who are reporting difficulty in areas of cognition, so remembering and concentrating, which really deserves sort of further exploration among this population in terms of why young people are reporting higher rates of these types of disabilities in a dedicated survey. And most importantly, because these types of disability can also have a significant impact on educational progression and enrollment if they're hindering learning and are not addressed through accommodations. So we see potentially quite a large sort of hidden burden of disability among young people. Turning then to health insurance, this is again census data. Among Jordanians with disabilities, about 30% had healthcare, did not have health insurance coverage. About 70% were covered with health insurance, but still about a third of persons with disabilities did not have health insurance coverage. This is similar, slightly lower, or slightly higher than the overall population. 70% of non-Jordanians with disabilities in the kingdom do not have health insurance. And this is again quite similar to the overall very significant gap in health insurance coverage among non-Jordanians. And the implications of this gap is that when individuals do not have health insurance and are faced with high health costs, they may avoid accessing services that they need or that could allow them to access assistive technologies or other services that could help mitigate the impact of the disability on their participation in society, or they may simply not be able to access services that they need for their health. This situation is particularly the case among young people. We see that among youth in general, rates of non-insurance are higher than they are among the overall population. This is the case in both the CIPJ and in the census. About 40% of Jordanian youth and 90% of Syrian youth in the CIPJ did not have health insurance. And essentially what we see among Jordanians is that employment predicts health insurance. As we know, many health insurance schemes are associated with employment. And also younger youth are more likely to be covered by health insurance, most likely because they are covered by their parents' insurance. So we are seeing a gap in insurance coverage among those older youth, sort of age 19 plus, who are no longer eligible for coverage under their parents, but who are not necessarily employed in jobs that would provide them with their own health insurance. And this again is leading to substantial coverage gaps among youth, including youth with disabilities, that may lead to avoidance of access of services or inability to access services. Using data from the Household Expenditure and Income Survey from 2013, we did look a little bit at the extent to which health insurance helps to mitigate out-of-pocket health expenditure. The HEIS used an older measure of disability that's not as nuanced, so likely disability is underestimated in the survey. So we did not find very strong associations between having disabled persons in the household and out-of-pocket health expenditure, although this may again be related to measurement issues. In general, though, we saw that of each individual member in the household who is health insurance covered was associated with a 7% decrease in monthly health expenditure at the household level. So this is very clear evidence that health insurance does in fact reduce health expenditure among households. And among the very small sample of households with a disabled member, when that disabled member had health insurance coverage, we saw a significant decrease in expenditure on pharmaceuticals and a decrease on expenditure in other categories, but the result wasn't significant, again, likely because of small sample sizes. So this is some initial indication that we do see health insurance does what it's supposed to, which is to reduce out-of-pocket spending, but we do need more data to be able to assess this on disability-specific factors. So to sum up also in terms of policy recommendations, as I mentioned at the beginning, Jordan has made some very important steps in recent years towards addressing the health insurance gap in general and towards persons with disabilities in specific. And really my main recommendation here is that we need evaluation and data to assess the degree to which these measures are closing that coverage gap. So one of these is that a voluntary enrollment was opened for the civil insurance program, essentially the Ministry of Health insurance program, for persons who are not employed by the government. There's a subsidized rate for older persons, which as we saw, suffer from quite high rates of disability. So this could be hugely important in addressing the burden of disability among older persons. We need to evaluate the extent to which they are in fact able to enroll. There was also implementation of a free CIP health insurance card for persons with disabilities under the National Disability Law of 2017. So the census data that we're seeing for health insurance predates this. So it's very important to have an additional sort of evaluation or more data potentially from the next census to see the degree to which this is effectively reducing that coverage gap among persons with disabilities. But there have been a couple of implementation challenges noted with the implementation of this free insurance card. One of which is that the definition of disability that's typically applied in administrative situations is based on a medical certification of disability. The criteria for which are likely to be more strict than people's self-reported sort of self-identified level of disability that we see in data sets like the survey. So it's very important from an administrative perspective, and this has been noted also by the Higher Council on Disabilities National Inclusion Strategy, to consider the definitions of disability that are being used for the purposes of health insurance eligibility, and to make sure that these are aligning with current international understanding of disability, not purely as a medical condition, but as an interaction between a person's functional capacities and the environment. Because this is really key to making sure that individuals who need it are eligible for the free health insurance. And then coming to the core of the topic of this session, finally, there is really a need to address health insurance coverage gaps among particularly vulnerable groups. One of those groups is youth. Again, we are seeing a gap among somewhat older youth and insurance coverage. This seems to be related, at least in part, to lack of employment that provides health insurance coverage. So extending non-employment-based insurance schemes to youth in the informal sector is very important. They may now voluntarily enroll in the CIP, but we don't know whether the cost is prohibitive. Another measure that's been very effective in other countries, including in the United States under the Affordable Care Act, was to raise the age until which young people can be covered as dependents under their parents' health insurance. So for example, raising this age from 18 to 22 or 25, so that young people have a longer period during which they can be covered by their parents if their parents are still employed. Another group among which we see huge coverage gaps is non-Jordanians. There's really not enough disaggregated data to rigorously assess where non-Jordanians are being insured and who is not being insured, because this is a very diverse population. So there needs to be more systematic assessments of the types of health insurance and access to health insurance coverage among the different non-Jordanian populations in the country, and an implementation of sort of new schemes to achieve health insurance coverage for these populations with an eye to concerns around fragmentation and access to appropriate services. And with that, I will conclude, and hopefully within my 10 minutes, more or less. Thank you very much.
Thank you, Dr. Maya. I think that was a very comprehensive presentation, highlights the different gaps that require closing with clear recommendations, particularly related to youth and non-Jordanians. So moving on to the next presentation, I know Dr. Maya has also been involved in this one, but I think the presentation will be by Ms. Zaina Jamaluddin, I believe.
Yes, hello, hi.
Alan, all yours.
Thank you. Can you see my presentation?
Yes.
Perfect. So hello, everyone. As noted by the moderator, I'll be presenting on behalf of also Dr. Maya Sieverdeen, and I'm looking specifically at the association between household food insecurity and subjective well-being, and so poor mental health among youth in Jordan. As you all know, and has been presented today, cash transfers have been a common form of social assistance in low middle income countries, and government in the MENA region have really increasingly shifted towards cash assistance. Those have been shown to have an impact on improving basic needs and covering basic needs. However, a lot of the assessments that looked at the impacts of cash assistance have focused really on children rather than on how this impacts youth in the households. And a lot of this research has been done in countries that are not in the MENA region and hasn't looked at specifically the transition to adulthood. If we look at a recent systematic review that we see the globe here, they looked at studies that looked at the association between food security and mental health. A lot of the studies were actually coming from high-income countries and no studies from the Arab region, or very limited ones. And so just to talk about the conceptual framework between cash assistance and mental health and improving subjective well-being, conceptually, cash assistance or giving cash would increase expenditure on food and so decrease food insecurity, improve food security. So there's lesser burden, lesser worry about stress regarding food. At the same time, cash assistance can actually also improve self-esteem and feeling of dignity to the pathway directly just by giving cash and enabling social participation, and thus improving subjective well-being. And so the aim of the study was really to understand the prevalence of cash assistance and the correlates of it in Jordan and households that have youth in them, and also later on to look at the prevalence of food insecurity, poor subjective well-being among Jordanian and Syrian refugee youth, and finally to look at what are the predictors of poor subjective well-being. And so basically we use the same data set that Maya just presented about the survey for survey for youth that UNICEF funded. And what we find at the beginning is that around 20% of Jordanian households with youth receive some form of cash assistance or social assistance, and mainly through the National Aid Fund. And this actually was, the receipt was higher among households who had female-headed households. So as you see in orange, female-headed households were more likely to receive cash assistance among Jordanian. There is not really a lot of difference in the areas in Jordan in terms of cash assistance. Now, when we look at Syrian refugee households, the majority of households, 90%, were receiving some sort of cash assistance, mainly from UN agencies, and 10% of the households were not receiving any assistance. The majority of the assistance came through the form of WFP cash assistance, and at the same time, only 5% received either UNHCR only assistance or UNICEF only assistance. But we also find around 12% of households received 3 types of assistance at the same time: the WFP, the UNHCR, and the UNICEF kind of assistance. And so if you also look specifically at camp settings, in the camp settings here, we see that actually the majority of the households receive WFP specific assistance. Now, how does this really translate into food security? In blue, we depict all the food secure, whereas in orange and gray, we see the moderately food insecure and severely food insecure. And among Jordanian, 55% of households that have youth were food secure. So, and around 45% were food insecure. And food insecurity was more likely to be experienced in some areas in the country, specifically in the middle region and the urban areas. And as expected, food insecurity was strongly associated with wealth. So if you are the poorest, experience the highest prevalence of food insecurity compared to the richest who experienced less food insecurity. When it came to Syrian refugees, actually the majority of Syrian refugees experienced food insecurity, around 74%. So only 26% of Syrian households were food secure. And really, this has had not a lot of association with other characteristics. So female-headed households, it really did not differ among the sex of the head of the household and in different areas among Syrian refugees. We see that in the south, there is quite a lot of moderate food insecurity experience. And this high prevalence of food insecurity indicates that potentially, although they are receiving a lot of cash assistance, but the amount of transfers are not really sufficient to cover basic food needs, and there's a competing interest in spending this cash assistance. And this has been also shown a bit in WFP monitoring, which actually showed high rates of food insecurity among refugees, despite them having food assistance. Now, when we are really talking about cash assistance and food security, we're also looking at how does this relate to subjective well-being among youth. And in Jordan, around 40% or 39% of Jordanian youth experience poor subjective well-being, whereas there are more prevalence among Syrian refugees who experience poor subjective well-being. There was no difference between if a young man or a woman in terms of how they experience poor subjective well-being, regardless of their nationalities. So there's very similar prevalences. Males, 38% were experiencing poor subjective well-being among Jordanian. It's the same thing for female, around 40%. But what we see is the fact that older youth were more likely to suffer from poor mental health. That if we see here among Syrians, 66% of those who were aged 25 to 30 report experiencing poor subjective well-being, whereas the prevalence is lower among 16 to 17-year-old who experience 33%. So around half of them, half of the amount. At the same time, attending school amongst Syrian refugee youth also was shown to be protective and actually to experience less poor subjective well-being. So among Syrians, if you're not in school, 62% were experiencing poor subjective well-being, whereas those in school experienced it 28%. The greater the wealth was associated with greater subjective well-being among Jordanians. So the richest had 29%, whereas the poorest had 53%. They had higher experience of poor subjective well-being. So this is really specific for Jordanian, but not for Syrian refugees. But for both Jordanian and Syrian refugees, having a disability increased the levels of experiencing poor subjective well-being. And so when we wanted to look at all of this together and what are the predictors of poor subjective well-being, we see clearly that food insecurity or experiencing food insecurity decreases your scores of having good mental health. So the severely food insecure had lower scores compared to those who were food secure. But however, getting assistance was not really a predictor for subjective well-being. So among Jordanians specifically, household receiving social assistance was not a predictor or did not really associate with improvement in subjective well-being. However, when we look at the Syrian refugees, we see the same pattern when it comes to food insecurity. So those who were food insecure had lower scores of mental health. But what we notice is that Syrian youth who live in households that receive 3 types of cash assistance, WFP, UNHCR, and UNICEF, were associated with better subjective well-being once we adjust for different characteristics in the model. This suggests that the amount of assistance may be of important factors between cash transfer and well-being. To note on the 2 big policy implications, there is definitely a need to further to do further incentives to provide food assistance for both Jordanian and Syrian refugees, really focusing on the amount and targeting of this, and this is what everyone has been discussing mainly, but also with the current COVID-19 situation that might have exacerbated the food insecurity situation in the country. Among Jordanian, there is a need to consider expanding the program from 20% receiving to more. But also among Syrians, there's a need to ensure other income-generating activities. There's also a need to expand school feeding programs. I know that in Jordan, there are some initiatives by WFP, but there's a need also to expand them further and to diversify this food and also targeting them not only for young kids, but also for the youth. In terms of the burden of poor subjective well-being, as we saw, this goes beyond food insecurity. So food insecurity alone is not only gonna alleviate improving food security alone is not only gonna improve poor subjective well-being. There's a need for a cash plus component or a cash plus intervention where a link between cash transfers happen with psychosocial support, with behavioral change, and with possibly some in-kind transfers. But that we need to do that ensuring that there is a proper access to services and facilitating the link to psychosocial support. So there's a need for interventions. And as Maya said, there are some that are currently conducted, but there's also a need for them to be evaluated, and possibly a targeted intervention for those with disabilities, as we saw that the people with disabilities have the highest percentage of poor subjective well-being, and that remains in all the models. Thank you so much, and I hope this was clear.
Thank you very much. Very clear and concise, and I think very important to highlighting of the links between food insecurity and subjective well-being as well. So moving on to the third paper that will be presented, we have a number of collaborators, Dr. Ragoui Asad, Dr. Elma Bustati, and Mr. Vishal Jamkar. On social protection for Syrian refugees in Jordan, and the reach and link to the multidimensionally poor. So the floor is yours.
Thank you very much. This paper is really quite complementary to the paper you just heard. We focus here on Syrian refugees and on households, all households that have Syrian refugees, rather than just those who have youth in them. Now, as the previous paper suggested, cash transfers have been shown to be a highly effective form of aid, where they provide autonomy and dignity for the people who receive them, but also they support local producers and market, as opposed to, for instance, direct food transfers or food subsidies, which provide less autonomy on the part of the recipients. However, we'd like to investigate in this paper really who gets access to transfers in the context of the Syrian refugee influx. In particular, do the characteristics of recipients vary within camp or non-camp populations? And keeping in mind that 20% of Syrian refugees in Jordan approximately reside in camps, and they usually are the more vulnerable among the Syrian refugee population. But also, okay, it's not on Zoom. All right, just let me. All right. Is everybody on Zoom seeing the screen now? All right. So basically, so one of the main questions that we try to ask in this paper is, do the multidimensionally poor get adequate access? So for that, we need to identify who is multidimensionally poor, and we use the well-established now Oxford framework to identify the multidimensionally poor and look at them in the context of camps and non-camps to see who among them is able to receive transfers and who's not. So just a quick word about the types of cash transfers. WFP used to provide food vouchers. Now, since 2017, these food vouchers have become cash transfers, unconditional cash transfers, and they're of modest amounts, so 23 JD per person per month for the extremely vulnerable, and only 15 JDs per person per month for the vulnerable households among registered Syrian refugees. And a very large fraction, 72% of Syrian refugee households receive these WFP vouchers. So they're quite fairly universal. In addition, as the previous paper said, there are two types of cash transfers by UNHCR, and they vary in amounts. Unfortunately, I have these in dollars, between $75 and $400 per household, depending on household size, and the UNICEF cash transfer, which is tied to going to school for children who are registered in double shift schools. We analyze both of these together as cash transfers, and so we look at whether you receive one type of assistance, WFP, or both types of assistance, WFP plus some cash transfer from UNHCR or UNICEF. Now, overall, we have 23% of Syrian refugees receive the UNHCR or UNICEF cash transfers, so they're less universal, but overall, 77% of refugees receive one form or other, so of assistance, and 55% only receive one only type of assistance. So these numbers may be slightly different from what you saw from the previous paper, partly because this is 2016-17 data as opposed to 2020 data, but partly because also we're focusing on all households among Syrian refugees and not just among those who have youth. And the analysis is, again, based on the Jordan Labor Market Panel survey, which dates from 2016 and 17. It was carried out by the Economic Research Forum in collaboration with the Jordanian Department of Statistics. And several of the papers you've seen today have used this data set, which is nationally representative. And in 2016-17, oversampled areas that had high proportions of non-Jordanians, including camps to get at the Syrian refugee population. So we have currently in this data set 539 Syrian refugee households that are both in camp and outside of camps, out of a total sample of 7,729 households in that data set. And we hope to be able to have a third round of the survey. This is already the second wave, to have a third wave in 2024 to follow up these households over time. Now, this is pretty good complement to the UNHCR data. UNHCR has very good data on refugees, but it's only for registered refugees. And as we will see here, there's a group of unregistered refugees, which is very vulnerable and is not captured by UNHCR data. So in terms of characteristics that predict the receipt of transfers in general, I try to kind of break them up here between those characteristics that increase the probability of receiving transfers, those that reduce that probability of receiving transfers, and then in camps and in host communities. So those in green are common between camps and host communities. The transfers are fairly well targeted to households that have a member with disability. Also, households that have a higher share of children are fairly well targeted with transfers. Those that don't have any working members tend to receive transfers, are more likely to receive transfers. And then those that reside in the northern region where most of the camps are and most of the services targeting refugees are. Now, within the camp setting, also those that have high share of elderly and are in the lowest wealth decile, so the poorest 10% of the population, tend to be favored with more access to transfers. Outside in the host communities, female-headed households are well targeted, as well as those with high incidence of food security. So you might think, how can they have high incidence of food security and be targeted? It's because, was mentioned in the previous paper, the levels of the transfers may not be sufficient to completely reduce food insecurity. Now, but more importantly, are which households are missed, and the we find that households with heads who are older than 60 and who do not have, so that's one group, and who reside in the central and southern region and have high levels of crowding. Those are within the camps setting. So there are certain vulnerable households. And I think the issue of heads older than 60, and also there is the fact that of no educated member in the household is often a barrier. And these may be barriers to negotiating the bureaucracy of access to these transfers. And so that's something that needs to be looked at. So that's, and particularly outside in the host communities, we will find that registration becomes an issue for accessing transfers, and households that have members older than 60 and members with no formal education tend to be less likely to be registered. Now, we adopted, as I said, this multidimensional poverty framework, which is, as I said, fairly well established. It has 3 large dimensions: education, living standards, and health. These 3 dimensions are equally weighted. They get a 1/3 weight each. Within each dimension, there are several indicators. So in education, there are 2 indicators of deprivation. Within living standards, you have 6 indicators of deprivation, and within health, you have 2 indicators. So food insecurity, for instance, shows up here as one of the health indicators. The other one we use is whether you have access to any kind of formal health facility when a member of the household gets ill. But it includes also variables that indicate housing insufficiency, whether you have access to regular housing or you're living in a tent or in temporary housing. Now, these indicators are combined in one index of multidimensional poverty. That index is a number from 0 to 1. If the index exceeds 1/3, then you are considered multidimensionally poor. If the index is between 0 and 1/3, you are multidimensionally vulnerable. You have some multidimensional vulnerability or deprivation, but you haven't quite reached the threshold of multidimensional poverty. And then if the index is 0, you have none of these deprivations. So 0, the orange is here people who have no deprivations based on this multidimensional index. The light green is they have some deprivation, and the dark green, they have more than 1/3 of deprivation in that index. And as you can see, Jordanians do fairly well. There are very few Jordanians who are multidimensionally poor based on that index, whereas 21% of Jordanians are between that 0 and 33%, they are multidimensionally vulnerable. Whereas if you look at Syrian refugees, overall, 12% are multidimensionally poor, and an additional 36% are multidimensionally vulnerable. So almost half have some multidimensional deprivation. Of course, if you look at the in-camp population, nearly 80% or 83% are either vulnerable or poor. And in the non-camp population, it's about 40%. So we're going to then look at this these categories of multidimensionally poor and multidimensionally vulnerable and see to what extent they have access to transfers. So if you look at, we have 3 categories. Either you access both types of transfers, and that's the orange color, or you access only one type of transfer, which is typically the food voucher or the WFP assistance, and that's the green, light green. Or you access the both types of transfers, and that's the dark green. Now, the most important takeaway from this graph is that the multidimensionally poor, who are, it's the bars on my right, are more likely not to receive anything than the vulnerable or the non-poor. And that's really, so 37% of multidimensionally poor Syrian refugees do not receive any transfers. And that number is the same whether you are in a camp setting or in a non-camp setting. That's a pretty shocking number, given that if you are in a less vulnerable, you actually have a much lower proportion of not receiving anything. So where are these people and why? It's a relatively small number. We're talking about 37% of about 12% of Syrian refugees. So a third of 12%. And we find that there is a very strong correlation with lack of registration, at least among those in the non-camp population. And factors that emerge as important, again, in limiting access to assistance are also important in limiting access to registration. And as I mentioned them earlier, the low education of household members. When you have no educated member in the household who has at least a basic education, having an older household head, and among the people living in host communities, living in non-standard housing. So these are essentially people living in informal camps outside in the host communities who are not covered by any services, and you find a strong correlation with lack of access to other services, whether they're health insurance or access to other health services. So this is why we need to look at data sets that don't just look at registered refugees, because you will find these pockets of very vulnerable refugees who have not managed to negotiate the registration bureaucracy. Now, as a conclusion, so we see that most Syrian refugees do receive at least one kind of transfer, but there are many vulnerability factors that are associated with non-receipt of transfers, and having an older household head and no educated members of the household are among them. Now, the fact that these are the higher proportion of the multidimensionally poor that don't receive transfers than those who are not multidimensionally poor, which means that there are pockets of vulnerability, of severe vulnerability, who are not being reached, and again, it has to do within, at least for the host communities, with being non-registered. Now, for the multidimensionally poor who don't receive transfers in the camps, that's a little bit more difficult to figure out why. They are clearly also correlated with they don't receive other services within the camps. So there are still groups of fairly vulnerable refugees in the camps under the eyes of the UN authorities who seem to be excluded. And that's a bit of a question mark in our eyes in terms of why that group still exists. And so I will stop here and hope to get some comments from the audience. Thank you.
Thank you very much. I think very important at different levels. الآن ننتقل للمناقشات. نبدأ مع السيدة لارا ياسين، مدير الدائرة القانونية المجلس الأعلى لحقوق الأشخاص ذوي الإعاقة. عندك يمكن 5 ل 7 دقائق.
يعطيكم العافية وشكرا جزيلا على استضافة المجلس في أعمال هذا المؤتمر، وتحديدا يمكن بهاي الجلسة اللي هي مرتبطة ارتباط مباشر بحقوق الأشخاص ذوي الإعاقة. بمجرد يمكن تعقيب سريع على الورقة الأولى اللي لها علاقة بتحقيق تغطية التأمين الصحي للأشخاص ذوي الإعاقة، بدنا نحكي يمكن بمجموعة من الأمور اللي تم تداولها في هاي الورقة، منها موضوع المصادقة يمكن على الاتفاقية الدولية وماذا يرتب، وموضوع البيانات، وموضوع المعالجة للأدوية، وموضوع التحديات. هلأ طبعا احنا بنعرف انه احنا في علينا التزام دولي من بعد المصادقة على اتفاقية حقوق الاشخاص ذوي الاعاقة، وبرضه الاردن يعتبر من الدول اللي صاغت كمان هاي الاتفاقية وليس فقط قام بالمصادقة عليها. بالتالي هذا بيرتب عدة التزامات دولية ووطنية على عاتق الأردن في هذا المجال، وطبعا هاي الاتفاقية تعتبر اتفاقية متميزة ومختلفة عن باقي الاتفاقيات. هلأ هي مكملة لاتفاقيات حقوق الإنسان، لكن تتضمن مصطلحات ومفاهيم خاصة بحقوق الأشخاص ذوي الإعاقة يجب عكسها على التشريعات الوطنية. من ضمن الالتزامات قديش بدها تكون التشريعات الوطنية متوائمة مع أحكام هذه الاتفاقية. طبعا بدأنا في المجلس يمكن من حوالي 2012 لحتى العمل على صياغة قانون متوائم مع اتفاقية حقوق الأشخاص ذوي الإعاقة، لحتى صدر اللي هو قانون حقوق الأشخاص ذوي الإعاقة رقم 20 لسنة 2017. والقارئ في هذا القانون يجد مدى الموائمة ما بين هذه الاتفاقية يعني موائمة القانون لهذه الاتفاقية بموضوع المصطلحات والمساواة وعدم التمييز في ممارسة الحقوق كاملة. طبعا لما بنحكي عن الحقوق بنحكي عن الحقوق المدنية والسياسية والاقتصادية والاجتماعية والثقافية، ومن ضمنها بدنا نحكي موضوع التأمين الصحي إذا بنحكي عن الحقوق الاقتصادية، وأيضا اللي هو التعليم والعمل. هلأ راعى كثير القانون كمان موضوع تحديد الأدوار والمسؤوليات، لأنه كانت هاي من الأشياء التحديات التي واجهناها في عملية صياغة هذا القانون. مثلا في موضوع التأمين الصحي كان في تداخل للأدوار والمسؤوليات ما بين الوزارات المعنية، سواء كانت طبعا الأساس اللي هي وزارة الصحة إدارة التأمين الصحي، ولكن كان في برضو تداخل مع وزارة التنمية الاجتماعية، وأيضا في الحقوق الأخرى زي التعليم والعمل وغيرها. هلأ في موضوع البيانات كمان، موضوع البيانات موضوع كتير كبير، وإحنا يمكن بنعترف إنه في عنا جاب أو في عنا ثغرات في موضوع وجود البيانات المتعلقة بحقوق الأشخاص ذوي الإعاقة. هلأ تمت الإشارة لموضوع التعداد السكاني والاعتماد على بيانات اللي هي 2015 اللي هي تحدثت عن إنه نسبة الإعاقة 11.2. هلا المفارقة كمان في هذا الموضوع إنه لما بنحكي 11.2 هي فقط إحصاء لمن هم 5 سنوات فما أكثر، بالتالي ال5 سنوات فما دون ما تم إحصائهم، وإذا صار في إحصاء رح تكون كمان النسبة لسه أكبر من 11.2. فبالتالي كل الأرقام اللي تم طرحها في المتعلقة بالإعاقة في تعداد 2015 رح تتغير، لأنه في نسبة كمان لم يتم إحصائها. هلا اعتمدت كمان هاي الإحصاءات على أسئلة مجموعة واشنطن، الأسئلة القصيرة كمان هاي والصعوبات الوظيفية، ما رح تعطي كمان إجابات واضحة خلينا نحكي ودقيقة عن موضوع الإعاقة أو حتى كيف عرفت الصعوبات الوظيفية أو الإعاقة. بالتالي تداركا لكل هاي الأمور حاليا بيتم العمل مع دائرة الإحصاءات العامة وأيضا مع مجموعة واشنطن على أنه يتم للإحصاء القادم أنه يتم استخدام اللي هي الأسئلة المطولة لمجموعة واشنطن حتى نحصل على يعني نسبة واضحة ودقيقة في موضوع الإعاقة، وأيضا تكون مبنية على التعريف القانوني الوارد للإعاقة في قانون حقوق الأشخاص ذوي الإعاقة رقم 20 لسنة 2017. وعم نشتغل معاهم على بايلوت بروجكت رح نعمل مسح للواء الكورة باستخدام هاي الأسئلة لحتى يكون للمرحلة القادمة للتعداد القادم يكون مفصل ليعطينا نسبة الإعاقة. هلا في موضوع كمان التأمين الصحي، أو خلينا نحكي في موضوع الحماية الاجتماعية للأشخاص ذوي الإعاقة. يمكن منظومة الحماية الاجتماعية هي ليست فقط التأمين الصحي، التأمين الصحي هو جزء من منظومة الحماية الاجتماعية اللي هي واسعة، اللي بيدخل فيها التعليم، بيدخل فيها العمل اللائق، لأنها هي حلقة كاملة ومتكاملة. لكن إذا أخذنا جزئية التأمين الصحي، إحنا في تحديات جذرية بتواجه الأشخاص ذوي الإعاقة في هذا الموضوع، اللي هو موضوع التشخيص وضعف التشخيص، لأنه إحنا بحاجة إلى تشخيص نوعي ودقيق لحتى يكون هو المدخل لعملية الحصول على الخدمات، وأيضا اللي إلها علاقة في موضوع التأمين الصحي. عشان هيك بموجب القانون أيضا تحدث عن أنه المجلس مسؤول عن إصدار بطاقة تعريفية للأشخاص ذوي الإعاقة، وهاي البطاقة اللي هي رح تقوم مقام اللي هي التقارير الطبية، وتكون البوابة لحصول الأشخاص ذوي الإعاقة على الخدمات الواردة بموجب القانون والإعفاءات والخصم الجامعي وتغطية التأمين الصحي. موضوع تحدي جذري موضوع إمكانية الوصول للمرافق، أو خلينا نحكي للمراكز الصحية، للمستشفيات اللي هي بتقدم خدمات التأمين الصحي. طب هاي مشكلة كتير كبيرة. إذا إحنا يعني فقط الموضوع إنه إحنا معانا الحصول على بطاقة تأمين صحي هذا لا يكفي، لكن جودة الخدمات اللي مقدمة وتسهيل وصول الأشخاص ذوي الإعاقة لهاي المراكز للحصول على خدمات التأهيل، على خدمات العلاج الطبيعي والوظيفة اللي بتقدمها وزارة الصحة. بالتالي القانون عالج كل هاي الثغرات اللي هي جزء منها اللي لها علاقة، بس عم نحكي على موضوع التأمين الصحي من خلال إنه نص صراحة على بأحكام المادة 24 على موضوع التأمين الصحي وتغطية التأمين الصحي. هلا النصوص القانونية كمان الواردة في هاي المادة اللي بتتحدث عن موضوع التأمين الصحي كانت نتاج لتحديات بتواجه الأشخاص ذوي الإعاقة في موضوع التأمين الصحي وأسرهم. من ضمنها اللي هي موضوع إنه إحنا كيف بدنا نوصل للمركز لناخذ خدمات التأهيل أو خدمات العلاج الوظيفي، أو إنها غير متوفرة مثلا، ممكن تكون في مستشفيات معينة للوزارة أو في مراكز بتكون بعيدة عن أماكن سكنهم. فبالتالي اجى القانون والزم على عده نقاط، منها اللي هي تم الاشاره له موضوع الاثمان الادويه والمعالجه، بحيث انه لا يستوفى من الاشخاص ذوي الاعاقه اللي هو اجور المعالجه واثمان الادويه، وهذا تم عكسه من خلال تعليمات من قبل وزاره الصحه. وايضا في اللي هو موضوع الصرف المستلزمات الطبية للأشخاص ذوي الإعاقة، لأنه إحنا بنعرف يعني موضوع التأمين الصحي بيشمل موضوع خدمات التأهيل، وبيشمل موضوع كمان الجبائر وإجراء العمليات الجراحية وغيرها. ألزم كمان إنه هاي كلها الخدمات المستلزمات الطبية بتقدمها الوزارة مجانا، وأيضا هذا كان ضمن تعليمات أصدرتها وزارة الصحة بهذا الخصوص. موضوع الوصول لهاي الأماكن بتطلب إنه قديش إحنا بموجب القانون متطلبات الوصول للأشخاص ذوي الإعاقة بدها تكون المستشفيات مهيئة لاستقبال الأشخاص ذوي الإعاقة والمراكز الصحية. هلا تمت الإشارة كمان، إحنا مش بس لما بنحكي عن التهيئة والوصول الكامل، الوصول الكامل بمعنى إنه أصل إلى المكان وأستخدم هذا المكان وإنه يكون متوفر. إحنا بنعرف لما بنحكي عن الأشخاص ذوي الإعاقة في عنا مصطلحات حقوقية ومصطلحات مختلفة، زي يكون متوفر ترتيبات تيسيرية وإمكانية وصول. إمكانية الوصول بمعنى أن تكون البنى التحتية مهيئة لاستقبال الأشخاص ذوي الإعاقة، والترتيبات التيسيرية قديش في أدوات ووسائل مهيئة للأشخاص ذوي الإعاقة أو الأشكال الميسرة. هذا كله بيوصلنا لإشي كتير مهم اللي هو التصميم الشامل. التصميم الشامل ليس فقط للأشخاص ذوي الإعاقة، وكمان له علاقة بكبار السن والنساء الحوامل وغيرهم. موضوع زي ما حكينا موضوع التأمين الصحي يمكن هو جزء من موضوع الحماية الاجتماعية، لكن هو بكون البوابة وأيضا التكاملية الحقوق اللي بيستفيد منها الأشخاص ذوي الإعاقة سواء بالتعليم أو العمل. يمكن هذا بالمجمل. يعني حكيت عن المصادقة البيانات.
شكرا كثير لك أستاذة لارا. طيب ننتقل للمناقش الثاني، دكتورة دينا الدجاني أظن معنا أونلاين.
مرحبا، شكرا لكم. اسمي دينا دجاني. أنا باحثة مختصة بالنزوح واللجوء الحضري. الورقة اللي انطلب مني عليها بالإنجليزي، فاسمحوا لي إنه حضرت ملاحظاتي بالإنجليزي بناء على هذا. Thank you very much for having me. I've been asked to comment on the policy brief by Asad Bustati and Jamkar on cash transfers in multidimensionally poor Syrian refugees in Jordan. It's a very important study that reveals many interesting camp-urban comparisons, pointing to the importance of context-specific or place-based responses. And what I mean by that is, as the authors found, which I thought was a very significant finding, that multidimensional deprivation was found to be double in camps compared to urban areas. And at the same time, that paper and the paper before it also noted that despite this, deprivation in urban refugees face more food insecurity. So that's what we That's what I mean by context-specific or place-based responses. And if we take those findings and put them in context, including some of the context provided by Professor Asad. So in Jordan, 80% of refugees choose to live in cities, 20% of refugees are in camps, but 90% of humanitarian funding goes towards the 20% of refugees in camps. And yet, despite this, as the authors found, multidimensional deprivation is still double in camps compared to urban areas. And it was the same also, nearly double for multidimensional vulnerability as well, not just deprivation, as Professor Asad noted. I therefore would like to take those findings with that context and consider how this should push us towards rethinking current approaches to aid. I think the policy brief provided, it makes an important contribution towards this need, looking at where and how to support refugees in contexts where they are more able to thrive, like cities, and then identifying what particular support they require, as well as host communities, and then also municipalities and local authorities that host urban refugees. This has actually been at the core of the 4-year multi-method and comparative research project we've been leading at IIED in 4 refugee hosting countries, Jordan being one of them, where we've partnered with the Phoenix Center, among other partners. And it's the largest academic camp-urban comparison that looks at refugee livelihoods and well-being. And I note here that Asad, Bustati, and Jamkar's findings on multidimensional poverty and cash-based assistance came with an important, and the differences between camp and urban, came with an important caveats, which he discussed also in detail in his presentation, which are that urban refugees that are undocumented are becoming an invisible population of refugees and included from assistance such as cash transfers, as well as health services. I would like to add identity education too, as I will elaborate on in a minute. And the author's analysis says that undocumented refugees are probably invisible to international organizations that provide social assistance, and that measures should at least be introduced to identify them and exempt them from registration requirements when it comes to receipt of transfers. And during his presentation, Professor Asad asked, who are those people? So my hope was to share a particular story to complement some of the statistical information provided by Professor Asad with some of the qualitative work we do, which also shares the stories of some of those undocumented refugees in cities. I know policy circles usually prefer statistics and numbers, but I hope the contribution of a mixed method approach that understands the experiences of undocumented refugees in their own words. Without that, we risk identifying also incomplete solutions. So in this vein, this is a single story of an undocumented Syrian refugee family in Amman. The interview was conducted by one of the Phoenix Center's excellent researchers, Sarah Al-Qda. I don't know if she's in the room today, as part of our joint project with them. So we spoke to Farah, a pseudonym, who has been living in Jordan with her husband and 2 sons since 2016. They have basic literacy. They learned how to spell their names and pronounce basic words, but that's it, making it more difficult for them to navigate what Asad, Bustati, and Jamkar called the transfer bureaucracy. So they're one of those families that the authors already identified as having are being more at risk of being left out. Their sons are 10 and 5, and they spent 2 years in Azraq camp and then left it through informal routes. They refer to themselves as escapees, translated from Arabic, and they've been unable to rectify their status and be registered as refugees in Amman. So are they invisible to UNHCR? So Farah tells us she approached UNHCR several times over the past years, 5 times to be exact, since 2018, when they moved to Amman. They just never hear back. This has implications on her children's schooling, as well as on their mobility in the city. So in Farah's own words, Having the UNHCR document is the most important thing when you move around. That's the first point. Secondly, there are people, it's not just me, many people that receive no food vouchers, nor monthly cash assistance, nor do they have documents. You do your part. You go and register. They ask about your first and last names, and you give them 2 phone numbers instead of 1, just in case there is a need for another number. And then they tell you to go home because they will call you. You have high hopes and keep on waiting for the call, but it just doesn't come. This remains the case for years, not months, and still there is no response. She continues, my children don't go to school because I've been outside the camp since 2018, and we don't have any documents, such as the UNHCR card for Amman. And every time I take him to a school, they just don't accept him. When they finally started accepting children from camp registrations at school, I also took him, but he has never been to school. And they told me he was too old at 10 years old to go to the 1st grade. I took him to several schools, but no school accepted him because he is too old. I went to UNHCR with this issue several times, and they told me they will call me back, but nobody has called, and I haven't heard anything from them. I went to the Ministry of Foreign Affairs and to UNICEF. I also called charities, but nobody has helped me with regards to my son's schooling because we are undocumented. So Farah's story, one of many, is critical in revealing 2 things. First, if undocumented refugees are invisible, it is not from a lack of them showing agency or trying to rectify their status, but from a humanitarian system that is currently not equipped to deal with urban refugees. Even when refugees make themselves visible to humanitarian agencies, they can still become excluded. While humanitarian agencies are increasingly developing the urban policy, the programming and processes to support such policies are largely lacking and lagging behind camp responses. The impacts this has range from lack of assistance, as Asad, Bustati, and Jamka note, to lack of access to basic rights, including education for children. I therefore thank the authors for the very important research and policy paper and welcome conversations that take seriously what an urban response to displacement can look like if a proportional representation of care, programming, and assistance was directed there relevant to the percentage of refugees who live in cities, over 80% of them in the case of Jordan. If, as Asad, Bustati, and Jamkar show us, urban refugees are more able to thrive in cities, then supporting refugees is even more critical, as is in ensuring that humanitarian processes and programs are set up and designed for urban refugees in order to leave no one behind. Thank you very much.
Thank you, Dr. Dina. And I'm aware of the time, so I think we'll take a round of questions from the room, and if there are any questions in the chat, and then go back to our speakers.
Thank you. My name is Afnan Abu Yahya. I work as a journalist and researcher at Ahl Foundation in Amman. My question regarding cash transfers and multidimensionally poor refugees, which Dr. Raji Asad talked about. I just wonder, since you mentioned that registration is one of the obstacles regarding the reachability of cash assistance, Syrian refugees in Jordan are registered and receive assistance through biometrics, and more specifically through their eye scan. I just want to know if the research investigates the effect of such digital means on delivering cash assistance in terms of social protection, not only in terms of seeking reachability, but also in terms of protecting refugees' digital rights. Thank you.
شكرا. ناخذ كمان إذا في أي أسئلة تانية. يس دكتورة.
شكرا. أنا عندي بصراحة استفسار، وهو استفسار اللي واجهناه كمان بالورقة اللي أعدناها اللي هي الأوفرفيو فريمورك، وخصوصا هلأ بهاي الجلسة حكينا عن ال vulnerable groups. يعني بحس مرات غير اللجوء السوري واللاجئين الآخرين اللي موجودين بالأردن، عندنا elephant in the room اللي هو اللاجئين الفلسطينيين. يعني إحنا لما عملنا الأوفر فريم ورك ناقشنا كتير أنا وزينة وتمارا كيف بدنا نتعامل مع لاجئين الأونروا أو اللي غير مسجلين بالأونروا، اللاجئين من غزة. لأنه لما الواحد يحكي بالتفكير الشمولي مش لازم ينسى أي فئة، وبالآخر قررنا نستثنيهم. وكمان وهلا أنا عم بسمع بهاي السيشن رجعت لهذا النقاش اللي إحنا دار بيناتنا، إنه كمان هاي السيشن اللي عم نحكي عن عندهم الحاجات الخاصة أو المالتي دايمنشنال بوفرتي، وناقشنا بين الأردنيين الفقراء السوريين داخل المخيم سوريين خارج، وكمان كان في استثناء للاجئين الفلسطينيين. فهو هيك النقاش، إذا عندكم أي ريفلكشنز بهذا الموضوع إنه كيف ممكن نكون أكثر شموليين بالمستقبل، خصوصاً من ناحية البيانات ومصادر البيانات المختلفة.
تمام.
في عندنا بس hand raised من مستر حسن الزول. ف if we allow him to speak for his intervention or question. Yes, the floor is yours, Mr. Hassan. He's not coming. They've taken care of it. Mr. Hassan, when you're ready, please let us know. So let's proceed and then.
Any questions in the chat? And then...
No questions, just the hand raised.
يمكن أنا بدي أعقب على كلام الدكتورة، بالإضافة للاجئين الفلسطينيين برضو ممكن نعتبر أبناء الأردنيات، برضو هذه فئة لازم نحطها بعين الاعتبار. أعتقد ما بعرف شو رأي العلم أو علم الاجتماع بهالموضوع هذا.
شكرا لك. ناخذ سؤال وراء.
Thank you for the presentations. My name is Meta Carlson, and I'm the head of cash operations for UNHCR in Jordan. I found the research that was done on the links between food insecurity and well-being. Those were not very surprising, but of course, it's always useful to see these relationships documented. Yeah. So. The presentation that was made on, hold on, let me get all the names. There were so many. Talking about the multidimensional poverty, very interesting. I know that I'm relatively new to UNHCR in Jordan, but I noted that the study was from 2016 to 2017, so it's quite dated. But for UNHCR, we would be happy to speak with you leading up to the next one that you're saying maybe in 2024, because in 2016 UNHCR shifted to a more sophisticated targeting model and are currently in the process of doing another targeting model. And your findings about households who with heads of households over 60 being less likely to receive assistance. I take that on board, and we'll look into maybe trying to figure out if that is still the case with the new targeting model that we have and that we will be rolling out. Also, I wonder in terms of the undocumented refugees, it's always really important to hear about these cases. It would be interesting to know to what extent this is an issue or a trend. I know that, UNHCR works in Jordan at the request and at the service of the government of Jordan. So there's a lot of things that UNHCR would like to do, but has to do necessarily in conjunction with the government. So any refugee that lives in a refugee camp or has lived in a refugee camp is registered with UNHCR. Whether they have a valid asylum seeker certificate is a different thing, because currently refugees have to renew their asylum seeker certificates every year. And there's obviously costs associated with that, mostly transport and things like that. So just that, those were just a few comments and observations from my side. Thank you.
Tamam, thank you very much. So we'll go back to the presenters now, and I think we have a number of questions. There was a question on the iris scans and digital divide potential implications. I think Dr. Mary raised an important question about the exclusion of Palestinian refugees, but I think this also raises other questions about other groups that might be excluded. And when we talk about undocumented refugees or unregistered refugees, it also what happens when we're looking at the implications when looking at non-Syrian refugees as well. So we'll give maybe just 2 minutes for each of the presenters if you wish to comment on any of these questions or any of the inputs from the discussants. So maybe we'll start with Dr. Maya.
I would just like to thank you for the comments and for the discussant for really hitting very comprehensively and in more detail on many of the policy issues related to disability and health insurance. I think it was a very nice complement to the data analysis in the paper and identified, yes, many of the areas where there's been a lot of progress and continued work to be done specifically on the data angle. So thank you. I don't have anything else from my side.
Thank you. We'll go to Ms. Zena.
Hi, thank you. So I just want to say that the point about Palestinian refugees is definitely on point. There's a need in the surveys to really focus on registered with UNRWA versus non-registered with UNRWA and what is happening. It was not possible in the survey, but it's a need to keep on that population in mind. In terms of one of the questions about digital, I'll let Ragi answer. But the main thing is that worries also about linking digital data with survey and really understanding all of that. There is an issue on vulnerable populations, and all of that has to be taken into consideration when we are thinking about cash assistance and digital transfer and looking at impacts of those. With surveys, but I'll let Dr. Ragi elaborate even more on that point. Thank you.
Thank you. So, Dr. Ragi.
Thank you very much. First, I'd like to thank our discussant, Dina Dajani, for a really excellent comments and very complimentary. We, of course, relied on our survey and quantitative data, but her bringing in the case of Farah to really illustrate the real lives of people who are suffering from this problem of being undocumented is really powerful. And I hope to be in touch with her to get some of that information. And also her point about the distinction between camp and non-camp populations and the need to take the setting in which the refugees live in consideration is really quite important. With regard to the use of biometrics and eye scans to register refugees, I don't have well elaborated views on that and what it implies in terms of privacy or but I do know that registration versus not is really important, that we need to find comprehensive ways to register all refugees, including those who seem to have a hard time negotiating the bureaucracy, to be able to be visible to the bureaucracy. And part of the problem is that they have to go through 3 registration processes. They register initially with UNHCR, and then they register again with the Ministry of Interior, and then if they want to live outside of camps, they have to get an asylum seeking certificate. So, and those often have to be done annually. So you really have a very complex system that not everybody is able to negotiate. And as a result, those who are not able to negotiate these systems live at the margins of society in a way that is really quite vulnerable and needs to be addressed by the way these registration systems work. And I understand that UNHCR does its best to register everybody on its radar, but it does have to comply to some of the rules set by the Jordanian government when it comes to registration. But besides that, I feel that there is also a group of refugees within the camp setting who are under the eyes of UNHCR, who are also to some extent vulnerable and excluded from some benefits. And I still have a question mark about them. What we know about them is they tend to live in very crowded conditions, and they tend to not have access to other services such as health care and health insurance. But in any case, I very much look forward to speaking to our representative from UNHCR about what we can do to better improve our questions in the next round of the survey, so to be able to capture these populations and complement the UNHCR registration data. Thank you.
Tamam, thank you very much. And if I can add a comment, I think when we look at the non-Syrian refugees and other groups, it's very important to look at them also as a source of lessons of what the trajectory is going to look like. We cannot assume that the cash assistance is still going to be there for the longer term. It's not sustainable. So I think that's something that's very important for us to look at and to be able to compare and to be able to think about ways that the availability of funds will probably decrease while the refugees will still be here. So there are a need for other solutions to integrate and include into the national systems. And otherwise, then the end result will be the trajectory faced by Palestinian refugees, especially the Gaza example, I think is very telling and very strong one.
Yeah, if I can just say, I mean, something to Mary about that. These people are identifiable in our surveys. We generally, there are silences, official silences about these groups and populations, but we do identify them in the surveys, and we can do special analysis about them, especially the Gaza refugees are neither Jordanian citizens, nor are they classified under the other Arab nationalities. So they're often called other Arabs in these surveys, which is, but they are mostly Gaza, and now increasingly Palestinians from Syria, who are also classified as other Arabs.
Thank you for the clarification. So I think we're almost at time. So thank you very much to the presenters and the discussants. And we'll go to the coffee break.